what we will establish is also evidence-based criteria for centers. The German Cancer Society will establish centers for gastric and oesophageal cancer, particularly to address the questions you have raised. Do you have in your centers already really evidence-based criteria for your centers in UK?
About 14, 15 years ago, there was a government-led initiative on a national cancer plan, which drove the initiatives of centralisation. Now, for things like breast, lung and colorectal cancer, the majority of your standard district hospital covering 350 or so, 350,000 population, that sort of activity can be done there. But OG, gynecology, some of the rarer urology cancers, there's no doubt you're having to work with units for the diagnostics and then the centres. And as a consequence, there was a document that produced standards against which individual centres were peer reviewed. That was part of the driver to reduce the number of centres down. We're currently in the process of repeating that exercise because of change in the way practice has evolved. And the current number of centres is 37, but the current activities, we're going to get down to about 26, 27. But we know there will be some people not impressed because practice will have to shift. And that's a very, very challenging thing to do.
Okay. And even more, I mean, I still feel guilty when a patient has to wait for 14 days until he gets the perioperative therapy. I saw in UK they wait usually 50 days. How can you reduce it? Is it just the amount of patients you have and you cannot cope with all of them?
No, it's a variety. It's like all these things, it's multifactorial. The original plan in the cancer plan was 31 days between presentation to primary GP and getting a diagnosis and a treatment plan, and then a further 31 days to get treatment underway. Now, because of the structure I've outlined with diagnostic centres in district hospitals and then the centres for treatment, you've got to get things completed in the diagnostic centres within all the other pressures of their other practice, then get the patient referred to the centre, and then with this, because it's so complex, with the interventional investigations, such as you might need laparoscopy, you might need EOS, it just takes longer. And we are now potentially fined if we don't get them treated by the 62-day target.
Bill, you did make a comment that perhaps we shouldn't be doing every staging investigation on every patient. Do you want to just...
Yeah, it's... colleague of Nick Maynard from Oxford has clearly shown that if you get for each patient, certainly endoscopy and CT cross-sectional imaging will give you your initial staging investigation if you've got significant metastatic disease. But I think you've got to use all the information you have available, even at that stage, to work out the indications for PET. Well, we've already heard you don't need a PET in diffuse type. Endoscopic ultrasound, we have cut down the number of endoscopic ultrasounds we've done because it doesn't influence what we do. Possibly the earliest, but our colleague endoscopy this morning says, as far as he's concerned, the best way of staging is an EMR and ESD, so you don't necessarily need US for them. Possibly in the T4, CVD penetration. And we had the discussion about laparoscopy earlier. So I think we've got to be more intuitive about the way in which we stage people.
I have a question to the salvage surgery. The data are very good data with long-term results. But if you look to the groups, you find different patients. The literature from the US, from Hofstetter and there is a big group of patients, they are not really salvage surgery, this is dilated surgery. After 8 weeks, 9 weeks, 10 weeks, 12 weeks. And there is another group, and this is for me the salvage surgery. Patients get a definitive radiochemotherapy and they came after 8 months with a recurrency locally, probably more. Do you see different results if you compare these groups?
This is what we've done in the paper published in the GCO. And we thought we would find a difference, and the literature was in favor of more difficult operation with less, well, worse outcome after delayed surgery, and we didn't find this in the study.
So I found it also quite interesting that you divided the patients between on-demand surgery and the patients with delay of surgery regarding recurrence. So on-demand seems to be quite the better population, isn't it right?
Yeah.
And but still, if they have had a higher irradiation amount of irradiation dose, it's still a high risk for them.
Yeah.
Yeah.
So yeah, the message is that oncology should not go up to 55 grade. Yeah. I know this is a recommendation, but there are also, you know, some trial of radiotherapy to increase the radiation dose. So there is a currently ongoing trial in France, which name is Concorde, and I think the phase 2 is finished, and now it's phase 3 is running, and but there is a safety analysis of those patients who would have to go to surgery in the group of patients who have a higher dose of radiation.
Yes.
Thank you very much for your talks. I have questions. First to Guillaume. If you go for a potential salvage surgery strategy, if you decide definitive chemoradiation, in which time interval after the completion of chemoradiation do you reassess persistence of tumor, and what methods, what diagnostic methods do you apply?
Okay, usually we do it between 6 to 8 weeks after. And we do endoscopy and TEP scan and CT scan. The result of the Presanos trials that are not already published but that have been showed in several congress show that probably we can, well, they do the first evaluation after 6 weeks, then they do a second evaluation after 12 weeks. And their results suggest that probably a new PET CT could be interesting, that EUS, not for the primary tumor, but for the lymph node, could also be interesting. And the third thing that they propose is to do bite and bite biopsies, because several papers have been showing that when you have persistent tumor, in most of the cases, it's in the mucosa and in the submucosa with a distance around 0.7 millimeters from the surface. And the usual biopsy go to 0.5 millimeters. So when you're doing bite and bite biopsy, maybe you probably identify patient with persistent tumor, and all those little things together, the association of everything, allows you to avoid to put in surveillance a patient who would still have tumor. Well, minimized, does not eliminate it, but probably minimized.
But you would not request histological confirmation of tumor persistence before going to salvage surgery. You would also operate if there is evidence from imaging without histological proof.
If there is progression on the lymph node, or if the progression on PET CT, I think no, we would go, because the histology is not so good.
Okay.
Histology alone, I mean.
Maybe, sorry. Do you think the molecular information could be helpful?
Yeah, probably. In the French trial, we're collecting the information of all patients who are included in the trial, meaning those who have no clinical complete response and those who have. So we will further analyze this, but yes, probably it's the key of the future.
May I also ask a question to Rebecca? It is about co-amplification. You showed the chaotic pattern of molecular alterations in esophageal cancer, and one of the problems you mentioned is co-amplification. And you said, so probably in the future we will need to combine molecular approaches. My question is, do you have any plan how to predict how the tumor will respond to your intervention? I mean, when you block EGFR, for instance, MET may go up or another pathway. And beyond combination, and you cannot combine everything, you probably need to predict or need a model to say this tumor will go into this or that direction. What is your plan for that? I'm curious.
That's a great question. I wish I had a very good answer, except to say it's surely very important. And we need to collect the information so that we can do those predictive correlations. And I guess that's also where things like ctDNA might be helpful, so that you can start to, especially if you're looking at if you're able to look at a lot of things with the ctDNA, so that you can start to see what resistances are occurring, what new changes are happening. I mean, there's a lot of these tumors are grossly rearranged at the beginning, so that's going to make it very challenging, really.
But so you believe in vivo liquid biopsies might be an approach? What is your belief in terms of models, ex vivo models?
There's a big effort to make a whole biorepository of organoid models. All models have limitations, of course. We've been working with the Sanger to try and make models for the cases that we're doing the sequencing in. And I think this is a step forward. In the past, the 2D cell line models have been extremely limited and with very little clinical information and no germline information. So I think the new generation of some organotypic organoid models are useful. And there's also the effort to do PDX models. We've not personally been doing that, but that's also helpful. So I think all of these things are relevant so that we can then understand. So we've just finished a large panel drug screen on a bank of organoids. And there are some interesting findings. We can also try and correlate those with treat them with chemotherapies and correlate those with the in vivo responses. There are some correlations, but there are some differences as well. So I suppose, like any model, the question is the degree to which it would then recapitulate what you see in vivo. And you've got the tumor cells there, you've not got the environment and so on. So they've all got limitations, but I'm sure they have their place. But trying to second guess what's happening next, which is I guess what you're saying, I think is going to be challenging.
So in that regard, you mentioned that the landscape of the genetic drivers in the tumors are very similar before and after chemotherapy. So that was struggling for me, because I thought there is some difference, and we could really take this information and then go on and decide what we could give. So, so what can we really say at the end? Is it the HRD, the homologous recombinant deficiency, as one important marker already, or is it, what do we have now already to use? You mentioned DDR deficiency.
Right. In terms of that, so I gave a kind of summary statement, I guess, is about the overall landscape is pretty similar before and after chemotherapy. But if you look in detail in a particular patient, there are some changes and some selection occurring mainly. So it is possible that for a given patient, you could start to try and look in detail at what's happening. So it's not entirely static, but because it's a very chemo-resistant disease, I guess it's not surprising that the overall landscape, if you take a bunch of cases and you take the chemo-naive piece and then you take a bunch where you've got the chemo-treated, basically you get back the same kind of information in terms of the point mutations, the amplifications, and so on.
John?
I just wanted to ask Bill about your last comment, last talk about the reporting to the public and the political implications. I guess one of the arguments about all this, of course, is that it's public money that supports all this. But I understand when the Dutch reported to the public, there was a rapid improvement in compliance with what was considered to be best practice. So you said it's been going for about 5 years and people have got used to it, but has practice actually improved through that public reporting?
It's difficult to say. I think it probably has. It's meant in particular, when it was first started, the national audit data was not designed to do that. That's been modified, and it's meant that for a starter, the quality of that data has significantly improved because it's ours. We've done it. It's our outcomes. I think it has actually improved across there's 10 audits that have been published in this way across the different spectra of medicine. They're all surgical, but it has certainly made, I think, colleagues think, is this the right sort of thing? For example, when you go into the detail for the esophagogastric resection numbers, the median was 14. And there was a very, very long tail with a lot of people doing single figures. And I think that group of people have stopped because they've looked at themselves in the morning and think, well, okay, I'm doing an esophagectomy today. Well, I did one 4 months ago. And I think people have recognized, actually, that's not the way to practice. And patients are encouraged to engage in conversations. And it's very useful to be able to say, well, my mortality is X. So that they appreciate what's going on. And I think that engagement with patients has made things more challenging because you're having to be very much more upfront with the discussions with the patient. But I think it means that the patient's receiving end has been better. It's probably a bit early to be able to demonstrate a significant improvement. But in actual fact, the emergency presentation has got less. So something's happening in the way things have gone about. We've certainly got better with regard to the management of Barrett's. We've got a more robust surveillance program and the centralization for people to have endoscopic interventions. So something has happened, but it, as ever, multifactorial, I suspect.
And just one quick follow-up question. I understand that these, when these type of reports are reported to the public, everyone's concerned that the public will look at this online and decide which surgeon or which unit to visit, but actually the public don't look at this at all, and it's merely, it's mainly our colleagues and peers that look at it.
Up to a point. There are, and it's not just a societal class, but dare I say it, issue. You get quite a lot of people who will go looking from all spectrums of society. Not many, but they will have looked you up.
So in that regard, we have been a little bit unlucky in Germany. I mean, the German Cancer Society has established 300 colorectal cancer centers. But nowadays, it's more or less a reason that the small hospitals survive, because they are still certified centers. And it's our feeling that it is too much, 300 colorectal cancer centers, because most of them are not high-volume centers anymore. So how can we reduce it, really?
Yeah, and there's another unintended consequence in that our trainees wish to be specialists. Now, we don't need large numbers of specialists. We in the UK appoint 8 upper GI resectionists a year, and the service needs those who can cope with the majority of the emergency practice, unselected emergencies in general surgery, for example. And we've got to try and find a way of rebalancing that, so there's some sense in the way in which the outcome from training meets what the service needs, and that's challenging too.
Okay, last question, okay, from Portugal.
This is for Rebecca, and 2 questions. Rebecca described these tumors with a huge number of molecular alterations, copy number changes, and other things. So this brings me to 2 specific questions. The first is it time arriving for specific NGS panels that could be used in practice? This would be the first, because you cannot go for exome or whole genome sequencing in every patient. So the translation to clinics would have to encompass such a thing. Is that in mind? Is it applicable, yes or not? And the second, that is related to the first, is with this huge amount of changes, you would expect high mutation burden. Is checkpoint immunotherapy being thought, tested?
I'll do the second question first, it's easier in a way. So actually one of our suggestions would be to think of checkpoint inhibitors in cases with a high mutation burden, especially as they're p53 mutant mainly. So I think that would be a hypothesis is ripe for testing, in my view. In terms of what kind of sequencing to do, what kind of panel, what kind of assay, I think actually that's quite difficult, and you need to think what therapy, what answer you're looking for, what specific question is, and then what the therapy is you're going to do, and then what's the appropriate assay. And at the moment, we don't really know that. We have lots of hypotheses, clinical trials we might want to do, but it's not as if it's very clear that we've got, you know, these 3 subtypes that need these 3 tumours, and therefore, and because it's so heterogeneous, you know, how big is your panel going to need to be? And for copy number alterations, yeah, some of the panels are better than others. You can look at focal amplifications and things, but here a lot of the copy number alterations are quite complex.
And the heterogeneity does not help, right?
Right. So it all depends the question you're trying to ask. So, you know, there are algorithms which will look at the copy number disorder, if you will, without needing to home down on a specific amplification that might tell you something about the tumour that would help guide the therapy. So, but in a trial setting, depending on what the numbers are, it may be actually going all out and getting a whole genome will enable you to then do more hypothesis generating and get more money, you know, more out of your money in the end, especially as the costs are coming down and down and down. But that's so that's something we're currently wrestling with how we go forward into the kind of prospective trial setting, you know, what kind of sequencing we do and what the numbers would look like and what the costs would look like. But I think going for too narrow a bespoke panel might be short-sighted actually, because the field is changing so fast, you might then end up not being able to change direction quickly enough in an adaptive trial design.
Okay, last questions in the back.
I would like to discuss shortly the issue of salvage surgery, and you frequently mentioned a cutoff of 55 gray regarding one group of patients with higher or lower risk of severe complications. In my opinion, this is not the optimal way how to investigate this question. In radiation oncology, it's mainly about the question whether we are able to respect well-defined, preset dose volume constraints regarding the organs at risk, for example, lung, heart, and so on. And if we are able, based on the use of modern techniques, based on our experience, of course, to respect such dose volume constraints, I'm sure we are able to irradiate patients, for example, with 60 gray, as safe as we do with 50 gray. So just taking older trials or data from older trials without such additional information and working out a cutoff as you did, this is not the optimal way for the future.
Oh, yeah. I fully agree with you. This is a very macroscopic approach of the problem, but it's a problem when you have, you know, retrospective data, and it's true there are databases which are mainly clinical databases, so maybe the GTV and so on is not included in this database, and probably this should be the cutoff may be modified according to the technique of irradiation. I fully agree with you.
Thank you very much for this very interesting discussion.